So the next speaker is Dr. Raghav Preetam. He's going to speak on Descemetopexy plus, a novel technique for incurled Descemet membrane.
Hello everyone, welcome to today's video on Descemetopexy plus, a novel technique for incurled Descemet's membrane detachment. A 57-year-old gentleman who had undergone cataract surgery 3 weeks ago presented with vision of 2200. On examination, had large DMD along the vertical axis with curling of the DM at the superior edge, which can be confirmed on the anterior segment OCT as well, and the IOL is pretty stable. Let us now look at the surgical video. To begin with, epithelial debridement is done and orientation of DMD is assessed. Due to the overlying stromal edema, details of the inward scroll are not very clear. We use an external light pipe to assess the DM position. As can be seen here, the margins of the scroll can be well demarcated with the inward fold can be made out. Then a side port is made and saline injected into the AC. Jets of fluid are injected and mechanical debridement is attempted. However, DM fails to unscroll. So the globe is made relatively hypotonous and our technique of single cannula unscrolling technique is attempted. Side port is made perpendicular to the long axis of the scroll. Then the orientation of the scroll is rechecked using a light pipe. Using a Sinskey hook, side port is gently depressed and multiple taps are being pushed over the center of the cornea. DM unscrolls as can be seen and confirmed with a light pipe. And then finally air bubble is injected and a full chamber air fill is achieved and left in situ. On day 1 post-op, DM is well attached and half chamber air bubble can be noted. On 1 week, the vision improved to 20/40 and DM is well attached and stromal edema cleared up, which is confirmed on the anterior segment OCT as well. To summarize, we have the case of Descemet's detachment with enrolling of the endothelial cells towards the stroma. By decompressing the globe and by using multiple thrusts, by creating the turbulence from center to the periphery, we helped to unscroll the curled in DM and using air, it was kept in position. We
So putting an air injection alone will not suffice if you have the proper orientation.
Yes,
curling and everything. Yeah.
Good evening, everyone. So that was a very important question. Thank you, sir, for that. So the whole reason why I put it up is because the DM is scrolled inwards towards the stroma. The moment you try injecting an air inside, it just gets attached in that position itself. It doesn't unscroll by its own and goes back to position. And I also demonstrated why we had to do this, because we tried to manually separate it, use the fluid to separate it, and it was not separating. It was 3 weeks past cataract surgery. There is some amount of fibrosis which comes there, which is holding it in position. So this is a maneuver because of the recent advances in performing the DMEC surgery, with which we have got more knowledge about the eddy currents which go inside the eye. So using that knowledge to use in a routine DMD post cataract surgery, we could save the cornea here.
So one thing is that we should have tried the simple way, what Dr. Vinod was also saying. If you would have tried that and if you would have failed that way, then I think this is fine.
So there is always a chance that once you inject the air can enter into the pocket of separation and can just increase the DMD as well. So that's another threat, because there is a good enough space there and also the curling inside. Either the curling can get fixed onto the stroma or the air might escape into the space, leading to much more DMD, making the whole configuration even more complex. So we didn't want to do that. We understood the anatomy first. We tried to separate it anatomically, structure by structure, and attach it in the correct orientation. That was the idea. It was 3 weeks old.
3 weeks.
So that's the beauty of it, ma'am. So once you get the orientation right, it's the patient's natural DM. Its original position is to stick to the stroma. So you don't need extra gas, C3F8, anything. The plain air itself will suffice the attachment, given that you are putting it in the right position from which it got stripped.
So can you visualize the curling during the surgery?
So we can't visualize it with the microscope. That's exactly why we got our light probe from the...
You have to use the endoluminator.
Endo illuminator again, the hands to work on becomes less.
Yeah,
So,
so-
this is an external light pipe which the retina friends use.
Yeah, that's what endo illuminator.
Yeah.
So endo
The endo
illuminator.
illuminator from the external
External,
side. Yeah.
so that's what
Yeah.
I'm saying. In fact, I've seen a case like this where the gas was injected on this curly DM and which didn't get unrolled, and it was a nightmare to reopen it. I will say very nicely managed actually. So but the trick here is you have to decide on table whether this curl is getting released or not getting released.
Correct. It has to be definitely visualized, and the endo illuminator helps doing
Endo
it.
illuminator really.
Yeah,
helps.
it works brilliantly. Yeah.
Endo illuminator with the room lights off.
This was Dr. Praveen Krishna.
Yes. Yes.
You should acknowledge that.
Yes, sir. I've given the name.
the
So,
slide it was-
yeah, I've given it in the slide. Yeah. Thank you.
Very nice.